My name is Claus Newman. I'm a retired consultant pediatrician. Part of my work when I was appointed as a consultant in 1969 to Queen Mary's Hospital, Roehampton, was to look after a unit of thalidomide affected children. It was then called the Children's Prosthetic Unit, after the so-called prostheses, that means artificial arms and legs that were being attached to these children. And because the health minister of the day got up in Parliament and said that these poor children would suffer terrible things in the future, and on top of everything else they would be sterile, that means they would not be able to have children of their own, my own researchers at Roehampton had pointed exactly the opposite way, that they would be quite normal, with a few exceptions. So I wrote to him, and his answer was not to give an answer, but to ask me to join what was then called the British Thalidomide Medical Panel. These were a number of consultant pediatricians who had been asked by lawyers to try and find some way of helping the lawyers to decide who was most and who was least handicapped, because they were judging the degree of compensation that the English courts were going to assign to the thalidomide children. And so in very little time we had to devise something how to compare blindness, say, with deafness, with limb loss and things like that. So we had a German schema from Philip Marquardt to guide us, and while we used some of that and various other techniques, we were able to come up with a scheme. This was called the Medical Assessment Scheme, or the MAP scheme. The British love abbreviations, maybe you do too. And anyway, the MAP scheme has, interestingly, survived and is still useful even now, because the very complex methods of assessing handicap and function, which about 3 or 4 years ago the Thalidomide Trust, who did some research, compared to the MAP scheme, we found that in fact there was something like a 95% fit in between our predictions and the current 40 years after assessment. So that was very reassuring. Anyway, I was responsible for that. Then when that particular work was finished, I worked with Sir Alan Marr, who was the English parliamentary ombudsman, whose job it was to identify any thalidomide sufferers among the so-called Y list. The X and the Y list, they survived from the early days of deciding who was a thalidomide and who wasn't. And we found about another 20 or more thalidomiders whom we judged to be thalidomides among the Y list. And since that time, I've been medical advisor to the Thalidomide Trust, and while I'm long retired from active practice, because of my age, I've continued to be medical advisor to the Thalidomide Trust in UK, and I've remained interested in this whole issue.
There aren't very many people that have your experience worldwide, are there?
Well, I'm afraid most of them have died, I think, and it's just a question of getting older.
But it is quite a complex investigation and subject, isn't it?
Yes, it is complex from a number of points of view. First of all, the whole range of things that thalidomide did is very wide. Thalidomide damages the growing embryo not in every possible way, but in many ways. Some of the ways it doesn't damage, for instance, it doesn't cause skin abnormalities, and you don't have people with thalidomide damage born with hairs of skin missing or severe scarring or anything of that sort. It doesn't cause a few other things, but it does cause a lot of damage. It can damage the eyes, the ears, the gullet, the upper limbs, the lower limbs, the internal organs, the reproductive tract. So a very wide range of congenital abnormalities can be produced by the drug. Having said that, one has to say also that thalidomide has not, to my knowledge, ever done anything that nature hasn't done before. The difference is that conditions that were extremely rare and continue to be extremely rare became much more common when thalidomide had been made available to mothers. It was a very, in many ways, thought to be a very satisfactory sedative because people couldn't commit suicide with it. And the damage to the peripheral nerves, causing sometimes permanent tingling and numbness and pain in fingers and toes, that wasn't recognized until a lot later. But so it seemed to be a very effective sedative, was widely taken by mothers. As a result, a lot of very rare conditions became much more common, and it was called quite rightly that this was an epidemic of limb deficiency. That was the most obvious ones. After all, if somebody is severely deaf, you don't notice it by looking at them, even though their ears may have been abnormal as well. Anyway, this epidemic in the popular consciousness is limb deficiency. But then again, it's also a particular type of limb deficiency, and it obeys a number of very specific rules to fit a pattern, and it fails to fit a different sort of pattern. So one can identify what can be thalidomide. On the other hand, you can identify what cannot be thalidomide when you are analyzing an individual's limb deficiency. And then there are a number of correlations as to what type of abnormality goes with what other type of abnormality and so on. So we do have a fairly sound knowledge as a result of a study of several thousand cases of the sort of things that were produced by mothers who either certainly or very likely had been prescribed thalidomide, and one assumes most of them actually took the drug. I've studied a lot of the literature, and I have found only about 4 instances where clear evidence of a very likely administration of thalidomide was associated either with a normal outcome of pregnancy or some condition in the baby that is not explicable on what we know about the drug at the moment. And you must balance that against several thousand cases where the outcome was as you would expect. So it is complicated.
Very complicated. What about today's genetic testing then? Could you talk?
Well, genetic testing can identify among the group of thalidomiders, there are some whom you cannot distinguish by examining them, except by waiting for them to reproduce. And there are some, for instance, the condition is called Holt-Oram syndrome, where you have a typical thalidomide type of short upper limb, a type of congenital heart condition, which you may get in thalidomide, and rarely knee abnormalities as well, which you may also get in thalidomide. And the only way of distinguishing a sufferer from Holt-Oram, on the one hand, with a sufferer from thalidomide, is whether there is a history of thalidomide or not, or whether their first-degree relative has the same condition or not, or nowadays, whether there is a particular chromosome abnormality that you can identify. And so when you look at the whole spectrum of thalidomide disorders, I'm quite sure that there will be more where one can identify a genetic abnormality, but one is really only talking about those where there is a father or a child, or mother or a child with the same condition. Only under those circumstances would a genetic analysis be important in defining who is and who is not a thalidomider.
But their fathers, would they necessarily know it? Would it also show with an abnormality or not?
Well, if it is a dominant condition, you either have the genetic abnormality, which is then revealed by a physical abnormality, or if you don't have the physical abnormality, in classical teaching anyway, so far, then you don't have this, and then you are a normal individual. There are some exceptions to this rule, but very few. If you have a recessive condition, that means you can be a carrier of the condition and appear normal. But then if you have a child with a partner who is also a carrier, then the child may be born with that condition. But this is classical genetics, And I'm a bit old-fashioned as far as that's concerned. I have not kept up with the latest.
But it surely is quite important to find this out so that these people don't pass it on to their future children.
Well, you would be surprised. Of the thalidomiders that I've personally examined or been in touch with and advised and so on, and there are now many hundreds, the number who actually looked for some kind of genetic guidance can be numbered on the fingers of one hand. Very, very few. It seems as if genetics is considered to be an abstruse discipline that is not to be approached, at least in England. It may well be different in Europe. Mm-hmm. Not that England isn't part of Europe, but at least we have this extraordinary scarcity of genetic investigation. It's expensive.
Uh-huh. So people try to avoid doing it.
Well, it seems almost as if they haven't thought of it, as if their medical advice hasn't considered the importance of it. I mean, if I had had a congenitally abnormal child, I would certainly have sought immediately to see whether there was any genetic reason for this, and if so, if one could identify it in another pregnancy. But there is a lot of difficulty. First of all, would you be prepared to have a genetic analysis if you were going to have another child? And what would be your action or your reaction if you got some information on that? How severe would the abnormality have to be before you considered, if you felt that morally acceptable, if you considered termination of pregnancy? If a finger is missing, clearly not. Probably not. If both arms are missing, if both arms and a leg are missing, if all four limbs are missing, you see, these are all difficult questions.